be here and to have the presentation about diagnostic angiography. In the beginning, I started to prepare the presentation, and I was thinking about which is old, which is new. And I tried to give an answer to that, but I'm maybe not that right. But also I want to discuss when do we need an angiogram. Maybe there's also over the time have been a change in the indication. If there's any alternative strategy or diagnostic procedure, and what are new tools available for us. So I think in these pictures it's clear to define which is old, which is new. If I go further on, I show you this angio, and I'm not sure if it's really an old angio. The method, it's maybe the technique, it's the same. We have a catheter, putting inside the vessel, giving contrast or dye, and have a picture of the vessel, maybe in 2D, what is missing here, this is a lateral projection, but this is the AP projection. This is today. The old angio was from 1994. This is today. I think it's quite the same. I can have a good picture of the ventricle, of the aorta, and I can maybe have also different informations. If I compare the old and the new one, I can quite see there's an advantage of the new method for us, for the people in the catheter, and also for the people who want to look up the angio maybe later on or during the clinical process. I think this is quite a big advantage. So another advantage is that today I think we have a reduction of radiation. We have an improvement of catheter material. We can use it and we can make the angio. And we also have improvement in the vascular access. So we have some new techniques available. When do we need an angio? I think the most important thing is in the upper part. We need it for peri-interventional procedures. And I think today we wouldn't do an angio in the majority of the pre-operative patients. But there are some questions which we cannot elucidate from echo or from the other diagnostic procedures where we might go for an angio. Also, we sometimes have we need the information about the anatomy. We need to know how the vessels are connected. Systemic or pulmonary perfusion is related to the ventricles. And we might just confirm the diagnosis which we made in echo. There's also a question for functioning analysis and also a follow-up indication. So peri-interventional, I think we saw it in the morning. There's a lot of information. If we look before and after the treatment, we have all the information we need to know. And for ventricular size, I think it is clear that we have echo and we have MRI, and we still use this. In addition, sometimes we need to know, like in transplant patient, is the ventricle have a regional wall motion disorder, have any region of discordance, and I think we use maybe Hashim's echo is still giving us an input, maybe to also give information additional to the angio. So we can analyze, we can size, and we have information about the ventricular performance. For coronary, we sometimes need to know if they are normal connected, or if they're like here, if they are not normal connected, if we have a kappa. This is quite an interesting information, and sometimes we cannot rule this out with echo alone. There are also more difficult cases, like here, where we have the circumflex artery only arising from the pulmonary artery. So this is, I think, also quite a difficult thing just to clarify this before the operation or during the operation process from echo alone. And we have coronary vasculopathy in the patients after transplant, where we also need to know within the follow-ups how the coronary performance is, how the coronary vessels are performing, and how or if we can exclude or confirm stenosis in these vessels. So another question is if there are any alternatives to angio, and I think yes, there are, as I already mentioned, and as we already heard. I think most interesting for the surgeon to prepare the operation, to give additional information to the angio is 3D echo. We can use it for TE, we can use it from transthoracal, And we have maybe an additional insight of the valve, of the performance of the valve, of structures, and of the relation to it. We can also use it for performance analysis, like as you see here in the right panel, 3D echo from the ventricle. It quite looks good and gives us the same, maybe the same information as angio does. MRI, I think we already heard, is giving us colorful pictures and good information, and also can go further on besides the anatomical proportion. It can give us gradients, it can give us flow velocities, flow patterns, and I think this is quite interesting. CT is also possible. We have to consider the radiation. We have maybe the possibility to look for structures which are maybe not accessible just in the thoracal part. So now we try to define what's about new. I don't know why it's flickering over the time. Pictures. Oh, good. Thank you. So, if we look for angio, we have maybe just one perspective, like the AP. We have the lateral view, where we have a two-dimensional picture. But also, I try to start it again, we can have a rotation. And this rotation gives us maybe information where we can look from different sides within the process of diagnostic or maybe interventional therapy. So how can we perform a rotation angio in these patients? You can see, I try to demonstrate here. Normally this is the patient lying on the table. We have the lateral projection and we have the AP projection, which is this coming over. So for rotational angio, we have to remove the lateral projection back to just the back of the room, and we just need the AP plane. And this can rotate, and we have to do a lot of adjustments. And we also have to be careful that there's no line, nothing else running from somewhere to the patient. So the patient has to be really by itself on the table, has to be sedated and everything. We can look for that. So, and then we can start the rotation. After we have found the start position and the end position, we know that it is mostly 4 seconds that we have to give, in this duration, we have to give the contrast medium, to give the picture, and you can think of 4 seconds, maybe a lot of contrast. So what we do is that we mostly dilute the contrast, so we have 15, 20 real contrast medium, which we are using. So how does it look like after we did this? It's like that. We have a rotational angio, in this case of the aorta, where we have a suspicion of aortic restenosis in this patient. And I mean, this quite looks normal, as we know from the normal angio. But then we have to start some processing, and which we are doing on site during the patient's lying there, and it's quite quick that we can make the calibrations for the best picture here. And we also have the angio projection over here. So now we can turn this around as we like, and we can see also which is the best projection to see the main pathology in this patient. And I can rotate this now, and I can see that the aorta quite looks not so narrow as I expected maybe in the beginning. And we have an impression over here, which is like an infold of the isthmus segment, and we have a post-stenotic dilatation. And after that, I can also make the measurements, and I can compare it. In the moment, we still compare this to the 2D or to the projectional measurement, and I think we have a good impression, and we can go and try to go on further if we need to intervene in this region. And in this patient, this is the lateral projection only. I think in the beginning we would say the judgment of this region might be more important as it looks in 3D. I would say that this is the impression which I get from the angio. Would I say this is quite a narrowing, but there was not a real gradient. This is confirming this, and the 3D, I think it's giving us some good information additionally to that. We have patients with stents where we have like post-stenotic dilatation, where we have overlay, and this is quite worthwhile that we can rotate this for the best projection, and we don't have an overlay for measuring, for visualization of this problem. Even in complex anatomy, you can use a rotational angio, as you can see, for pulmonary artery or pulmonary atresia, and we can see that we have a good impression of the stenosis, like here in the left pulmonary artery, where there's also a stent inside, and we have not the problem of overlaying for measuring also in those patients. Can also might miss in the lateral or AP projection an aneurysm of the aorta. If we do different projection, we come nearly to that what we can do with just one angio, one rotational angio, to see how big is the aneurysm, how far it goes, and what can we do, how are the underlying or structures in the region of this problem. And as you can see here, also we might miss some aneurysm in the stent, in the part of the stent, when you see rotating, that there is some projection where we don't see the aneurysm in this patient. If I try to compare, for example, CT, flash CT, which comes near to that, with the angio, I can think of, it's quite difficult to compare this, but for a patient where we try to compare it, I think the flash CT is still giving more radiation to the patient than we can do with the rotational angio, and we did 2 minutes of fluoro or 2.5 minutes of fluoro, and maybe have half of this with 2 rotational angios. So another point is what is mapping? I think mapping is also a quite near technique. The main point is that we can take the MRI data of this patient and put them in our cath lab, in the cath lab machine. Then we have the possibility that we have a segmentation tool where we can define the vessels or the ventricles at all, and we can choose, as you can see here, which vessel we wanted to look for. And this is quite possible. I can exclude maybe the pulmonary, I can include the pulmonary. It depends on my intervention, what I want to use. And after this, I can put it in a like projectional view where I can see which is the best projection also for my pathology again, where I can see it. I can see which is the best angio projection for that, and I can do maybe the angio. And this is a patient where we have done this. It's an isthmostenosis, as you can see from MRI data. We have put the MRI data inside our machine, and we can then look. We have always the MRI data underlying here, but we can then, with the reconstruction, look for the narrowing. And then I have a quite circumferential picture in my angio, and I can put this together and overlay the MRI data in my fluoroscopy. How can I do this? I have to do 2 different angios because the machine has to calculate this. And if I have done this, like you can see here, this is a difference of minimum of 30 degrees. I can then have a good mapping of my MRI data for the aorta and for my fluoroscopy. And I can also do the intervention, as you can see here. There's a multi-purpose catheter inside for the measurements. I don't maybe need angio. I wouldn't rely on the moment, but it's still in progress. But I can think I can do the pullback and the measurements for just from the MRI data, confirm it maybe with the fluoroscopy data. In addition, I think in comparison to the morning session, now we have pictures and colorful pictures in the cath lab. I think this is quite important. So, and can also do the intervention. I hope this is working here, the stent implantation, within the sheet still, then we can look for structures. I can also mark my landing zone or my structures which I don't want to reach, like subclavian artery. I can put the stent inside, see the balloon, and you can see that this is also working with moving pictures. So I have maybe just an additional information and orientation for the interventional procedure. Again, so it is possible for every structure, and then really can mark my points. I can see where I'm going, and I can also just do measurement, as you can see here, with a multipurpose catheter and the presentation for melody, where I might look for the main stenosis, and I can also put in the coronary picture, which is not quite so good because the vessels are quite small, but I have additional information during the procedure. So in conclusion, angiography is a useful tool. Still old or new, it is necessary for most peri-interventional procedures. It is also sometimes necessary in the diagnostic process of patients undergoing surgery or post-surgery. We have good alternatives with echo, with 3D echo. We have good alternatives with MRI and maybe also CT. We hope that we can a little more getting impact from the new rotation angiography and the mapping with the MRI data, maybe reduce radiation, maybe have better planning of interventions, and we hope that we can bring this further on. I would like to thank also the guys who are working with us, like MRI guys and the CAS lab guys. Thank you very much.